Welcome, Dr. Berdia. It's so good to have you on this subject that is both enlightening and very serious. Today we're here to talk about St. Charles Infusion Center. And I'd like for you to open up to our audience what this infusion center, how it serves our public, how it serves people that need it.
Part of the infusion center is we provide medication that needs to be either given intravenously or intramuscularly to patients with a variety of disorders, including people who have dementia, as well as other conditions, neurological conditions that require IV infusions. That's the part of the infusion center at St. Charles.
If we could bring it back to what is the exact difference between dementia and Alzheimer's?
In my viewpoint, the American Academy of Neurology or the American Medical Associations defines dementia as person who has problems with memory as well as cognition. And in terms of memory, there are three parts of the memory that we commonly use. One is called encoding, and one is retrieval, as well as information that we store in our brains. So that's the memory part. Mm-hmm. And the cognition part requires things like attention, things like judgment, reasoning, and problem solving. So part of dementia is basically a symptom of something. And Alzheimer's disease is one of those problems that dementia has. So we can talk about dementia like Alzheimer's disease, vascular dementias, Lewy body dementia, as well as like frontotemporal dementia. And there's a mixed dementias too that we commonly see. So that's sort of a difference. And dementia is a symptom of something. It's not a diagnosis. As well, people, when I see patients in my clinic, that's a frequent questions that happens is, do I have dementia? And dementia, we all have trouble with memory. We do, we forget our keys, we forget our wallets, right? So that's that's problem of recall. It doesn't mean that you have problems with encoding or, storing information. So, and when it involves those other two domains as well as encoding and remembering, that sort of qualifies with dementia, as well as reasoning, having poor judgment, right? They'll go out in the cold without their shoes on, mm-hmm. right? We commonly see that. And paying attention, I've had spouses tell me, look, my husband or my wife, it doesn't pay attention anymore. And that's the attention part. And those are some of the symptoms that we start to see with Alzheimer's disease.
I understand. Thank you, Dr. Berdia. I did a little research, and I was astounded by some of these numbers. I wonder if you could back me up. 500,000 people, it's 500,000 people 65 and older live with dementia in New York State.
That's true.
Yeah.
Between 30,000 to 50,000 people do have Alzheimer's disease in New York State. And overall in in United States, about 4 million people.
Okay.
And it's a very common disease, actually. And recently, there's been a big talk and a lot of media uproar about these two medications that have been FDA approved and that are very, I think this is the beginning of treatments, because since 2003, there has not been any medication that has been FDA approved for Alzheimer's disease. And in the last 2 years, these medications have been approved.
So when we talk about these types of numbers, something occurred to me. Since we're so good at making people, well, we're not really good because not a lot of people living past 100, but we're certainly living longer as time goes past. So I said to myself, if we're living longer, we have to have, just by definition, these numbers go up, right? For the number of people that end up with dementia, just by the fact that we're getting older and we keep ourselves alive. Is this part of the statistics that are going up?
So the statistics between the ages of 65 and 75, the statistics actually, as we get older, get increased. And at the age of 80, about 50% of people will have Alzheimer's disease. And that's devastating to a family. And the other thing that I usually see in my clinical practice is, I've seen, people bring their, parents. And now I'm seeing the people who brought their parents, they're coming to the clinic with the similar problems, and they're asking me questions like, Dr. Berdia, am I going to get the same thing as my mother or father had? And that's the key. I've been in practice for about 30 plus years, and that's what I've been seeing.
You've been seeing
more and more of these things where the people used to bring their parents, and now their same people are bringing themselves to my clinic to see if I have the same disease.
So
Hereditary is one of the factors, and it's been closely looked at, and these are some of the things that we monitor. If it's hereditary, we have to have there are blood markers that we can we can check in a person and try to figure out if they have a hereditary part of this disease process.
Yeah, I also want to get through some other truths or fallacies or rumors. What about diets, particularly sugars? Is this bringing on more of the disease?
The way I think about this is it's multifactorial. Diet can be one, toxins can be one, environmental causes, genetic causes, lifestyle. If somebody has a sedentary lifestyle, they're more likely to have this disease, as well as their education. If somebody is not educated or, has high school sort of an education, their chances of developing Alzheimer's disease is a lot more, or somebody who's been to graduate school, even though their genetic profile is similar. So having education is one of the negative, not a negative factor, but preventive factor, actually.
So you're really saying keeping the mind moving. I know my grandfather was a musician, and he was actually studied at Cornell University at 95. He was playing saxophone still, and we came to the point that because he kept wanting to figure out music, that his mind just kept moving. And he had no signs of this at all.
And that's the key portion. You just said it, sir. If you keep your mind active, physically fit, learn new things. That's my mantra. Learn new things in life. And even if you're getting old, just a little learning on the YouTube or anything else besides what you do at home, I think helps a lot. So if you use it, you won't lose it. If you don't use it, you'll lose it.
Right.
That's the mantra, too.
We're going to get into the center itself, but I want to ask you, there's a few famous people that have had Alzheimer's or dementia. Do you want to speak about those just because they might be examples of what happened to them?
Well, famous presidents, right? Ronald Reagan actually passed away with Alzheimer's disease. And you could see the decline, actually, and in the social media at the later stages, he was not even portrayed. And that's sort of a problem, because I think this is a country problem. So the more people portray it who are in limelight, I think there'll be more research that needed to be done, and more treatments will come out of it.
So we take somebody like Bruce Willis or Robin Williams, both, I wouldn't say old by any means, but yet had started to show signs earlier, 50s maybe.
True, and this is a disease that, you're right, those two other people that you just named, they didn't have Alzheimer's disease per se, but they had a different forms of dementia. But actually, I would agree, that the signs and symptoms of these dementia or neurodegenerative disease start way earlier. They do. They start way earlier. And it could be simple thing as, forgetting your bank username and passwords. And that's a common theme, or the spouse will say, he's not paying attention. So these are some of the signs and symptoms that we and people ignore these because they're saying, well, he was just not paying attention. And as things progress, it's harder and harder to treat these people. So what I would like to do is, in our Dementia Alzheimer's Center, is to catch these people earlier on in their disease process so we can treat them and hopefully prevent their progression to other stages of this neurodegenerative disorder.
So when you go into trying to pinpoint when something is started so that you can start treatment, how soon will you do that? I mean, we all said we forget a wallet, forget keys. That's certainly not a reason maybe to go into an infusion center. But what is the tipping point for when these services are used in the center?
Well, it'll disrupt a person's daily life.
Okay.
When we start to see that, you're constantly repeating the same. The spouse will say, I repeated the same answer 5 times.
Mm-hmm. Mm-hmm.
That's even late for me to see them, but it should be very earlier when I think a person starts to themselves figure out, why am I not remembering these things? Why my memory getting poor? That's when I would like to see them in my clinic, and start the workup actually.
Understood. So let's get into the nuts and bolts of the actual infusion center itself, Catholic Health's Dementia and Alzheimer's Center at St. Charles. What specifically are services that someone can take advantage of?
So it's a sort of a multidisciplinary sort of an idea that we thought about, including, evaluation for people who have memory difficulty. I have a neuropsychology team that works with me. I have a nursing staff that works with me. I have a pharmacy team that works with me. And, the whole hospital itself is geared towards taking care of these people, as well as, we try to help people when they're in the hospital too, because we commonly see people getting admitted to the hospital and it costs a lot of money. People with Alzheimer's disease, when they come to the hospital, it requires a whole team of people to help, because, honestly, they don't understand the implications. There need to be a family involvement, social work involvement, nursing involvement, medical doctors' involvement, hospitalist involvement.
There's a lot of involvement, and what's peculiar about it is it's not like you have an acute, laceration or something that might be so obvious. As you said, it can be slow in its progression.
That's true, and there's a lot of stigmata too, if you don't mind me telling you.
There is, yes.
That people try to hide. Oh, my spouse is having difficulty with memory, and they try to hide those symptoms too, because I think that's cultural, partly, and partly not understanding the disease process.
Sure.
Because I don't think, since 2003, there's a lot of education in public. It helps to do these sort of podcasts to help the public out to see, look, if there is trouble, in the family, I think, if it's diabetes or hypertension or seizures, it's easy. But when it's memory, it's difficult.
Sure, absolutely. Now, just to be clear, correct me if I'm wrong, there's no actual cure for Alzheimer's at this point. We are trying to, you as your team are trying to slow the progression of such and catch it early, right? There's actually no cure for this, right?
That's true, because as our nervous system degenerates, at this point, there's no cure for it. That's correct. We're trying to, slow the progression to go to a next stage in their disease process, and I think what we'll be seeing is not 1 or 2 treatments, but multitudes of treatments that will happen to sort of abolish this disease as time goes on.
When we speak about the Dementia and Alzheimer's Center, what actually is the difference between dementia and Alzheimer's?
Sure. So dementia is a sign, like fever is a sign.
Gotcha.
Fever can be caused by viruses, bacteria, fungal infection, COVID-19, cancer. These are all things that can be caused by fever. Fever can be caused by these things. Same thing with dementia and Alzheimer's disease. So dementia is a symptom or a sign of Alzheimer's disease or vascular dementia or Lewy body dementia, just like fever is a symptom.
Got it.
Of something.
Yeah, no, that's very helpful.
Right.
Thank you. So when a patient comes in and they suspect that dementia is coming to fruition. The family is surrounding the patient, so to speak. Explain the process about, what each step would be, and then into the infusion center, and then the process there as well.
Sure. So the first thing, is to recognize, for me to recognize, is there, is this dementia? Are they having trouble with cognition? Are they having trouble with memory? And the first thing I need to make sure is there's no treatable cause. Things like vitamin B12 deficiency, things like medications that they take. They might be taking medication for their prostate that might be interfering with their cognition. So the first things I need to eliminate before I even make a diagnosis is to make sure there's something treatable I can see. So the first things I do, if they've had strokes, I get an imaging study, or I do blood work to make sure there's not, even hypothyroidism can be cause of their dementia. So
Okay.
I need to make sure that there's nothing treatable. And those are the first steps that I do. Then second layer of thing, that's my first layer. The second layer that I do is I do blood work, or we can do blood markers for Alzheimer's disease in the blood, which are now available in the last few years that we could do. Those I generally do as a reference point, because after the treatments I try to repeat them again to see if those numbers
Sure.
have gone down. And there's a new technology where we could do PET MRIs. And there are certain radio tracers that we use that look for these pathological changes in the brain called amyloid plaques. These are seen in people with Alzheimer's disease. And I look for amyloid plaques in these PET scans, and they also give you a centiloid score at how much the burden of the disease is. And then after we start the infusions, there are two types of infusions that I do have, and I'll talk about it. And what I've seen is we've been doing this for about a year now at St. Charles. And what I've seen is since the infusion, I've had one person, since the infusion, their amyloid PET scans have reduced centiloid scores from 98 to 40s. So the burden of the disease have gotten down, and there's been improvement also when the spouse came to my clinic last week, and they said, he's been more interactive.
Excellent.
He's more attentive to the surroundings. So there's real change and slowness of progression of Alzheimer's disease.
That's great to know. That's great to know. What you just explained, how new of technology is this right here?
It's in the lab. I mean, the technology is old, but it's, since the FDA has approved it about 3 to 4 years ago, we've been using it consistently with each patient. And also the Medicare people also require this as their preliminary to get these medications on board. So there's an oversight from the Medicare department also that we have to register our patients when we start these medications to them.
So the idea is the infusion center right here in Port Jefferson at St. Charles is going to be a real leader in breaking through the treatment of this disease.
I agree, and I'm acting as their center neurologist to help people in my community who suffer from this disease process, and I'd like to help.
At the center, in addition to the early onset infusions, what other infusions are offered at the center?
We do multi infusions, including immunoglobulin therapy, infusion for chronic rheumatological conditions, as well as infectious disease antibiotics we do, as well as iron therapy. And there's recent migraine therapy that we've been using too, that I'm familiar with because I'm a neurologist, for migraines. There is medication that we could use. Somebody who suffers from chronic migraine, we have a medication that we use IV therapy for, as well as blood transfusions we could do. So we're equipped for all of this, and our nursing staff and our whole hospital is geared towards helping people when they don't need to be in the hospital. We can, certainly do them as an outpatient. And that helps the patient, and they don't need to be in the hospital, and we can continue the therapy as an outpatient.
Can you let me know typically, and maybe there is no typical here, but in a typical infusion, how often and how long is that infusion therapy for a typical dementia patient?
So there are 2 infusions that are currently FDA approved. One of them is called lecanemab, and this infusion is every 2 weeks. And we have to do certain, they have to qualify with certain criterias that we have to do imaging studies before each of their infusion to make sure there are no side effects, because these medications do have side effects, and these side effects including microhemorrhages in the brain, as well as swelling in the brain. So we have to be very careful. So before each infusions, I have to get an MRI or an imaging study done. So lecanemab is every 2 weeks, and then the second agent that was recently introduced or FDA approved, that's every 4 weeks we have to do. And prior to each infusions, I have to get an MRI done to make sure there's no side effects like hemorrhages and edema. So it does carry a little risk. But the rewards are a lot better than the risks.
Right. Dr. Berdia, everybody's had somebody around them that's gotten older. And I'll mention my mother-in-law.
Sure.
Okay? She's 94. She is in perfect health, cognitively perfect as can be as a 94-year-old. My point is this. I noticed that people in my family, as they got older, they wanted to maintain their independence. Sure. They don't want to give up their car. They don't want to give up their daily rituals of going to the store and things like that. Is this one of the goals?
Absolutely. That's my personal goal, actually, to make sure they live independently. I'll give you a little example. One of my patients, that I've been diagnosed with Alzheimer's disease, or beginning stages of Alzheimer's disease. It was unfortunately, because their family members basically restricted him for driving their granddaughters and grandchildren around. And that sort of hit me and says, in order to maintain independence, they need to be involved 100%. But unfortunately, their family members or their children said no to having their dad drive the grandchildren around. And that bothered me.
Yeah, that's tough.
So, that my goal in this, situation is to maintain independence as much as they can, even driving their little grandchildren around.
Right. So really success, if it was 3 to 5 years and it was staved off, because we mentioned there's no actual cure, that is life-affirming. That is, a reward for this treatment. This is good.
And to get them to the next stage, from, say, mild stage to moderate stage, and if they can maintain their independence by driving, maintaining their own home, maintaining their own lifestyle, I think that should be our goal.
Mm-hmm. Doctor, what are the things that we can do physically, possibly, right? We talked about cognitively preventing. Can we do anything physically to keep this disease staved off?
So there are several things that one can do on their daily routine. One is to have some sort of I'm going to say exercise, but I don't mean going to the gym, right? Have some sort of an exercise regime on a daily basis where you change your clothes, change your shoes, and put 5, 10, 15, half an hour every day, Monday to Monday. Some sort of a routine where you stretch, you walk. You don't have to go to gym.
So intentional motor skills.
And you have to prepare for it. It's, when I work in a hospital and I have to walk, from patients to patients or from floor to floor, that's not exercise. That's work. When I do exercise, meaning I have to change my mindset, I have to change my clothes, I have to change my shoes, and your mind should be prepared for that. We walk up and down the steps all the time, but that ain't exercise. What do I mean by exercise again? And I'll repeat it again, is you have to change your mindset. And once you change mindset, your brain changes. Actually, they have shown when you do exercises, your metabolism in the brain changes.
Definitely.
Oxygen level changes in the brain. Your mitochondria gets more active in the brain, in the nerve cells. So exercise, so that's one. Proper diet. I think also diet plays an important role in this. Eating, processed food. That's not one of the things that I would recommend. Eating healthy, vegetables, colors. And the third thing I will say is social. Be social. Be involved in activities around your community. Be around other people. So there's a lot of socialization, and people who live 100 years and plus, they always talk about social aspect of their life. And those are the three things I think about that we can change on a regular basis,
Absolutely.
on a daily basis.
Is there any reason to believe that the phone is internalizing some people to not go through some of these
Absolutely
exercises?
correct.
Yeah.
Absolutely correct. Because with the phone system, everybody's looking at their phones and not being social.
Right.
Social, even,
They
eye
think they
contact,
are, but they're not.
eye contact, touching, going places and meeting people.
Well, I want to thank you for enlightening us on this very serious subject. I appreciate that.
Thank you very much for inviting me, sir.
Absolutely. Thank you.